Orthopedic Advanced Learning Sessions. In this webinar series, we invite eminent international pediatric orthopedic surgeons to share their vast experience with our fellows. Pediatric orthopedic surgeons have found such sessions so interesting that now many professors and senior practicing surgeons also tune into these sessions. The topic for today's is a very difficult topic, the management of limb deficiency. Particularly, we are going to focus on the lower limb. And we have an eminent expert on the topic, that's Michael Schmitz. He is the Chief of Orthopedics at Children's Healthcare of Atlanta, which was previously the Scottish Rite Hospital of Atlanta. He also serves as a co-director of spasticity clinic at the center. His clinical expertise is complex spine deformity, congenital limb deficiency, and cerebral palsy. And he's not only a clinician, but he's also a great innovator, and he has many patents on his name. And he has played a very instrumental role in growth modulation device for scoliosis management, that's Vector and the Magic Rod. So he's having a vast experience, and today he's going to share his experience with us. So over to you, Mike.
Okay, well, thank you for that introduction. You know, we always say with our residents, fellows, and partners that we're learning together, and that's a lifelong thing. So hopefully we'll continue that today. And I'll tell you, here in Atlanta, it's 11:30 in the morning, and it's about 45 degrees out, which we think is really cold. Fahrenheit, 45 degrees. All right, let me go to the share here. I'm going to share my screen. All right, there we go. All right, move that right up there. Okay, so we're going to talk about limb deficiency in pediatric patients. And as we discussed, this is a really broad topic. And so in putting this talk together, I felt like I was leaving so much out with each one of them, but we're going to move through things pretty quickly. I'm hoping everyone will see some commonalities in the different limb differences that we talk about. So the first thing that I would say is the treatment goal in any limb deficiency can always be summed up in two words, and it's maximize function. And when we look at the function of the lower limb, there's really two primary things that it's there for. One is to be weight bearing, and the other is for propulsion. If you look at a normal limb without the skin, we would say that one of the things we want to do with weight bearing is be a shock absorber. And we have some specialized sub-Q fat across the heel and the bottom of the foot that helps us do that. And then we have shock absorbers at each joint, because each joint has some material properties, and the cartilage, the metaphyseal bone, and then the muscles, but also a structural property that when you put those all together, what we're really trying to do is have that limb almost function as a shock absorber. And that shock absorber is through the joints as well as the material properties. If you look at propulsion, we take that same shock absorber model, and now we add the muscles to it. And when the muscles are added to it, they are essentially the spring that in an eccentric contracture can help absorb the weight-bearing forces, but in a concentric contracture can actually propel you across the ground. And if we saw that person running, take that spring and put it in their limb, where you're basically catching yourself on the way down and then propelling yourself forward. That's what your limb is really trying to do. When we say, well, what are the things that we do to help that happen? Well, it's a couple. One is you want to make your limb painless. And a comment that I would make is when you're looking at limb difference, pain changes everything. If something hurts, that's a significant degradation to your function. Secondly, you want to preserve your lever arms, preserve your power, your muscular strength, preserve biologic joints. And the prosthetic manufacturers hate it when I say this, but I would say even a not so great biologic joint functions better than a prosthetic joint. The one thing that really changes that is pain, and that a prosthetic joint is never painful. We want to preserve motion. You remember that spring that we were defining? If you don't have motion through those joints, you have ruined your spring. And then we want to be able to prevent future problems. And we'll talk about a few of those in the pediatric mind space. So remember with that spring, by preserving our biologic joints, we're able to absorb pressure across there and also improve our function as long as we can make that joint efficient in that it maintains its range of motion, can move smoothly and without pain. And then when we add our muscles, that's what's putting our power on there and then our motion for propulsion. So how do we do this? Well, it's a lot of people. It's not just orthopedic surgeons, but it's physical therapy, it's the prosthetics department, orthotics department, plastic surgery for our skin and soft tissue, vascular surgery in case we have to do a revascularization, dermatology, and physiatry. And the point I would really want to make is it's really a team effort. And to have a successful limb difference or limb deficiency program, you don't have to have all these people there all the time, but you certainly have to have access to them. Now let's talk about from the patient perspective, what does maximize function mean? Well, that's the parents asking you, can they walk? Can they play? And can they be like any other kid? And the goal is to be able to say yes, yes, and yes. And even when we say be like any other kid, we say they're a special kid because they have something that the other kids don't, but they're still in the game, they're still on the field, they're still at school. One example that I'll show you where there's multiple ways that can hold you up is I'll show you this image of a transtibial amputation. And as we get through the talk, you'll see this is something we don't like to do, a mid-bone amputation. And you see why we don't like to do it, because you can have some difficulty with overgrowth. But that was not what was holding this patient back. It was her skin. This was a lawnmower injury and had all kinds of difficulties with our soft tissue and skin that required our plastic surgeons as well as our dermatologists with this infection. But once we got that under control, this is for the first day she received her prosthetics. And this is something that you will never see in an adult. But in kids, you put the prosthetics on and they get up and walk the same day. And then 6 months later, they're running with those prosthetics, not using crutches at all. So the outline of the talk, that was just a brief introduction, and then we'll talk about how pediatric limb deficiency differs from adult limb deficiency. We'll talk about the pediatric limb difference specific problems. We'll talk a little bit about a congenital versus acquired. And then we'll talk about the tibial deficiencies, fibular, femoral, and then we'll have a little bit on prosthetics and get to questions. So in terms of the hosts, one of the ways that they differ, and when you look at a pediatric host, they're usually A1 hosts. These are usually pretty healthy kids, and even when they aren't, when they're syndromic kids, their soft tissue envelope is usually great. They have unlimited cardiopulmonary reserve, and their occupation is always the same. It's play, and that's one job that every kid wants to get back to. Contrasting with adults, adults can be really variable in their host, and probably because they have comorbidities that have been going on for a long time. Compared to a child, their cardiopulmonary reserve and strength is a little bit different. And the way I would describe it is if a 6-year-old kid trips and falls out in the parking lot, they get up and run away, maybe with a scrape on their knee and they need a Band-Aid. If a 70-year-old trips and falls in the parking lot, they might need to be carried away and carried to the emergency room where a fracture or some other injuries are being taken care of. The other difference with adults and kids is that occupation that adults have, they might not be able to return to after limb deficiency surgery. But their play is something that they want to get back to, and there's certainly ways to be able to do that. In terms of the types, when you look at our pediatric patients, most are congenital. They usually involve the upper extremity and are often have multiple limb or other associated abnormalities. And when I show you this picture, we show this to our residents and say, hey, show me where the limb difference is. And everybody focuses on that right upper extremity. And I'd say, well, that's the easy one. Take a look at their thighs. And you can see on the right is significantly shorter than the opposite side. And the astute observer would notice how that foot is in a varus position and question whether or not there's a tibial deficiency as well. When you look at the adults, most of the amputations are acquired. usually in the lower extremity, and often isolated, meaning everything else is perfectly fine. And the classic adult amputee patient that you would think of is the adult vascular patient who has a lower extremity amputation associated with either vascular disease from smoking or peripheral vascular disease or vascular disease from diabetes. All right. When we look at the etiology between pediatrics and adults, again, in the pediatric world, congenital is by far and away the most common. And then the two types of acquired being traumatic and disease. And then you say, well, what kind of disease causes an acquired amputation in kids? It's really three things. It's malignancy, vascular disease, or an infection. When you look at adults, it's just the opposite in that most of the limb deficiencies are acquired, with disease being actually more common than traumatic. And when you look at what kinds of diseases, most commonly vascular, sometimes infection, and we could have a big discussion on whether that infection is really a vascular problem. And then finally, malignancy. All right, let's talk about pediatric traumatic acquired amputations for just a minute. These are very different than congenitals. With a congenital limb deficiency, that's something to the child, that's how they've always been. And so their ability to cope with it and move through life is often much better than our traumatic acquired amputations. And the reason with trauma, there's a sense of loss. You had something and a functional level that is now gone. And that degradation in function is immediate. It usually doesn't take over time. And then oftentimes, to their advantage, the limb is otherwise normal, and that most traumatic amputations are transverse. Some of them you could say are considered intercalary, where you see this injury. This is somebody who was out hunting and had a rollover in a vehicle that rolled over his arm. But really, that distal extremity is not very functional. This patient had about 8 hours of warm ischemia time out in the field before they were picked up by the helicopter. Other times we can see a very transverse amputation here where everything distal looks to be pretty intact. This is a patient that got to the hospital very quickly, but when you look at those nerves, those are root avulsions from the spinal cord, which is essentially an unreconstructible brachial plexus injury. So unfortunately, even though this patient made it to the hospital quickly with a limb that was relatively intact, its neurologic injury precluded any limb salvage. When you look at pediatric limb deficiency from trauma across the age, you see a high proportion of these happen in very young children. And then there's a little spike later as adolescence, where I would say that child's mind reverts back to a toddler mind. And when you look at that big spike in the younger patients, everybody says, well, who is that? I don't think I see those patients. And it's mainly upper extremity, and it's usually fingertip amputations, which functionally don't have a huge hit on your function, but still count in the registry as an amputation. 33% of traumatic amputations are in children, and that comes out in the United States to be about 10,000 amputations per year. Their mean age is about 6 years of age, and the disability cost is actually pretty big in that their mean number of surgeries is about 4, and often with a 4-day hospital stay each time, and that's usually for wound management. When you say, well, how are we getting all these fingertip amputations? There's a primary causative factor, the door. And that's where you will see these signs, please don't slam the door. Another cause that we see here a lot in the United States is lawnmowers. Either a kid out trying to mow the grass and they pull it back over their foot, or a kid riding around on grandpa's lap on the riding mower and gets dropped and then accidentally run over. The garage can be a dangerous place. And if you look through this garage, there are all kinds of ways for little kids to get hurt. You can see a fan over on the side, bicycle wheels hanging from the ceiling, and multiple drawers that have heavy tools inside. The garage is actually a pretty dangerous place for a little kid. Let me show you an example. This is a patient who was riding on actually was walking behind a riding lawnmower that grandpa was driving. Grandpa did not know that the kid was there and inadvertently backed over him. And if you look at this image, the tibia fracture jumps out at you. But if you look at the soft tissue, you can see significant disruption even on the X-ray. When we look at the patient, you can see that there's an open tibia fracture, and this is the wound that we see and we don't like. An open wound where somebody basically took a blower, that mower, and blew all kinds of dirt, grass, and debris right into the wound, severely contaminating it. Here we are washing that out, and you can see how we've lost that flap on the heel, have significant degloving of that limb, and an open fracture of the tibia. And there you're looking at the heel and the tissue. We ended up treating this patient with an external fixator that went across our tibia fracture. And if you say, well, why did you have that external fixator go to the opposite side? It was to protect our cross flap. Where this flap was raised on the opposite side, you need to keep about a third of its circumference attached, and that'll provide adequate blood flow without identifying a specific vessel. That stays in place for about 4 to 6 weeks, and by then we have able to have enough invagination of the capillaries here that they're going to be able to support that whole flap. So we take it down from the opposite leg, and this flap gives great coverage, does not require a vessel to provide it. The only disadvantage is that it's asensate. So although this is excellent coverage on the heel with excellent tissue, it's not sensate and does need to be protected. But going to this from this is a pretty big win, and that's something that you're able to do in children. All right, when we look at the different other kinds of acquired, when we look at the malignancy, this is an X-ray, and we kind of play this little trick on our residents. We say, hey, can you show me where the problem is? And they go, yes, it's right here, and do this giant circle. But if you look closely, you can see the change in our proximal tibia right here with new bone that's forming. And on our MRI, you can really see the extent of that tumor, and then unfortunately also a skip lesion up in the femur. When we're looking at malignancy and thinking about limb salvage versus amputation, we have a little checklist that we go through, and number one is survival. You always have to have life over limb, and if the limb salvage has a lower survival rate than amputation, amputation is the way to go. The second is function. And we'll go back to our little diagram, and we're saying, gosh, once we do that limb salvage, are we able to do what we want? Preserve a functional joint and preserve muscular power to make that limb work well. And if we can't, then we're probably looking at an amputation. And then finally, we talk about our intervention dose. With an amputation, the good part about it is it's usually one surgery and then you're done. The bad part about it is now you have to live with a prosthetic, and you have your prosthetic maintenance that's going to be for the rest of your life. When you're looking at limb salvage, it's usually more than one procedure. The limb you're left with doesn't require a prosthetic, but usually requires some specific management to maintain that limb over time. And that's what we're weighing. What's going to give us the best outcome over time? And then when we talk about vascular, you say, what kind of vascular disease do children have? This is a patient with Klippel-Trenaunay-Weber, which is basically a congenital malformation of your venous system, where your venous system ends up being these large vascular lakes as opposed to vessels. They can suck up a gigantic amount of your cardiac output, make a limb that's huge, very heavy to move, and non-functional. Many times these are handled with some vascular procedures, but often end up with an amputation to create a more functional limb. And in terms of infection in kids, usually something else is going on. So this is the picture of a patient with myelodysplasia and asensate limbs that ends up with an infection, and without great skin care, often end up losing some of their limbs. Let's talk a little bit about pediatric specific limb deficiency problems. And this is one that I want to show you that in the traumatic amputations, you can make a gigantic difference in that patient's eventual outcomes. And that's terminal overgrowth. Terminal overgrowth has a relatively high incidence with a through bone amputation. So remember that very first patient I showed you with that transtibial amputation. Through bone amputations is something we really try to avoid if we can plan around it. It's appositional growth, so this is not physeal growth, but it's growth at the end of the bone, almost like a fingernail. And as that fingernail continues to grow, it'll end up developing a bursa over it, which is painful, will keep the patient out of the prosthetic, and can actually grow through the skin and end up getting infected over time. Only happens with through bone amputations, and it's usually not a problem after age 12, which is interesting. This is not physeal growth, it's appositional growth, but for some reason that appositional growth does not seem to be very significant as that patient nears skeletal maturity. Most common affected bones are the humerus and the tibia. And let me show you some different things that we've learned in some cases. So this was a paper out of the Shriners Hospital just a little bit to our north, and it kind of has an unusual title, and it talks about operative treatment of bone overgrowth in children with acquired or congenital amputation. Really, the title should have been in children who have through bone amputations in both acquired and congenital etiologies. And they looked at 31 resections, and if it was just a resection, their overgrowth rate was about 84%, very, very high. In the patients who had a resection of a through bone amputation and then had some type of synthetic graft that was placed over it, they didn't fare much better. They had overgrowth about 78% of the time. If they had the amputation and had an autogenous cartilaginous graft placed over at the end, made a big difference in that their overgrowth rate went down quite significantly. The method that they were advocating was basically splitting the bone on the end and using a piece of your iliac crest, keeping that cap, putting it on the end, and hoping that that cap was act enough as a cartilaginous joint to almost fool that bone into thinking that it was a through bone amputation, which has an overgrowth rate of essentially, a through joint amputation, which has an overgrowth rate of almost 0%. In another study, also at a Shriners Hospital, they looked at surgical management with a synthetic cap, and specifically it's PTFE, which is Gore-Tex. So these are vascular Gore-Tex grafts that you basically cut to cap the end of the bone and use a purse string. The way that I describe it to our residents is imagine that the cut into that bone is leaking bony elements out the end that end up turning into overgrowth. If you can cap that with this Gore-Tex cap and stem that leak, then you don't have a problem. And here in this study with only 17 amputations, they had about a 30% revision rate, which mirrored what the other study had seen with the cartilaginous graft. What's some of the best autologous material? Not the iliac crest, but metatarsal or metacarpals, as well as your fibular head. And let me show you some cases. So this is a patient who had a femur fracture treated in a spica cast, and it was at an outside institution that made one of the classic mistakes with the spica cast in the femur, and that's putting a short leg cast on and using that short leg cast to provide traction while you wrap it up into a long leg. The problem is the top edge of that short leg cast can sometimes pinch and then cause some trouble. So here's this patient with a significant compartment syndrome that ended up being an amputation. What you see here is the metatarsal head of the first metatarsal of that foot, and then the fourth in the fibula, trimmed, and then I'll show you in the next slide how we incorporate those in. But what that looks like later as that bone heals in is it almost looks like a cartilaginous end on the end of the bone and really precludes any overgrowth. So if you're in a situation with an acquired amputation and you have excellent cartilaginous caps that you're basically throwing away in the red bag, keep those, and you can put those on the bone to save them. Here's a patient who's a congenital fibular deficiency who had a transtibial amputation. That's what they look like clinically. Here's what they look like once you get through the skin, and it almost looks like a fingernail that's growing. We were able to take the fibular head and then incorporate that in as a cartilaginous graft as well. This is back to our trauma patient, and this is that initial trauma with a dysvascular limb. One of the advantages of having partners is it was one of my sports partners that was on call sending me these images. And so I'm sending her a marked up image of where the bone cut should be, and then what type of tissue to harvest distally. So we're going to use that distal ulna as our cartilaginous cap. And here you can see the standard way that we do it, where we harvest the cap. We're going to take suture through a drill hole into the canal, down through drill holes here, up and out through a drill hole. And then you take that suture material and pull it tight. It pulls that right up in, and then we'll suck that right into the bone, but you don't have to have any hardware in there. It's only the suture. And then here's our flap coming over it. And then you can see here, we have how it comes right into the bone. And let me move this up a little bit. And then you can see how that's incorporated very nicely into the bone and healed with a cartilaginous cap, essentially fooling this humerus into believing that that was a through bone amputation as opposed, I'm sorry, a through joint amputation as opposed to a through bone. All right, when we talk about pediatric limb difference, we're going to talk about amniotic band syndrome. So these are our congenitals, tibial deficiencies, fibular, femoral. We'll talk about the classification systems, why those systems aren't so great, and we're going to talk about determinants. And I would say the determinants are the things that you're looking at that helps you decide how to get your best functional outcome, what procedures in line, and then we'll look at treatment. So a broad classification system, this is the Franz and O'Reilly classification, and it's probably the most common. And here, our deficiencies are divided at first into terminal versus intercalary. And think with intercalary, all that means is distal to the deficiency, you have an intact limb. And so you can have central where you're missing everything, but have intact elements distally, or paraxial where you're missing part of it, either the fibular side, postaxial, or tibial side, preaxial, but have normal tissue distally. When we talk about a terminal deficiency, that means that distally, something's not normal. It can be close to normal, but is not normal. And you'll see how you can have a fibular hemimelia that can be either a terminal transverse, a terminal paraxial, or actually an intercalary paraxial. So that can be confusing in the way that we describe things. But the advantage of this system is when you do a search on words like hemimelia or phocomelia, you're going to be able to find a lot of the articles. And we could go through a number of different deficiencies and talk about how they would be classified with Franz and O'Reilly. Here, we can see some terminal transverse, and this is basically amniotic band syndrome. Here we see nubbins from terminal transverse. Here, we can see that something is missing on this side. So we say that it's a periaxial, it's actually postaxial, and this would be terminal because we're missing some toes. So although that foot looks pretty good, it's not completely normal. And if we look at the x-ray, you can see this is a complete fibular deficiency or complete fibular hemimelia. Let's talk about amniotic band syndrome just a little bit. This is not genetic. Usually happens about the 12th week of gestation, can be very variable. And that these amniotic bands, every womb has amniotic bands. Most of the time, they don't get wrapped around or anything that causes a problem. They can be terminal, and if they wrap around your head or neck, that's going to be a stillborn, but oftentimes are around fingers and toes. Here we can see some terminal transverse amputations. And when you find one, look at everything because you're often going to find another. Here's a patient with a pretty significant one that went around the skin and very much affected the tibia, almost looked like a tibial pseudoarthrosis. Here we had plastics do a release. That's actually a metacarpal external fixator that we use for our reconstruction. That's how we looked leaving the OR. And here's the patient walking into the office 12 years later with a functional limb, but his primary complaint was his limb link difference, which we were able to fix over time. All right, let's go to our tibials. So by definition, a tibial deficiency is a reduction or absence of the tibial element within the long axis of the limb, but may have intact skeletal elements distally. Remember, that's going to be your intercalary deficiency, and they can be partial or complete. This limb is a giveaway in that if you got the x-ray, you're only going to see one bone. Sometimes it's hard to tell if that bone is the tibia or the fibula, but the answer is look at the foot. If your tibia is missing, your foot and ankle are going to be in varus. If it's the fibula that's missing, your foot or ankle is going to be in valgus. So here, looking at the foot, I know this is going to be a tibial deficiency. When we look at our x-ray, you can see that there's only one bone, and it's hard to tell, is that the fibula or the tibia? But looking at the foot, I know which one it is. All right, in terms of the genetics, a tibial deficiency is the one congenital limb deficiency that's associated with genetics being an autosomal dominant inheritance pattern. The clinical picture is going to be a rigid equinovarus foot, a shortened leg that can be variable, and then deletion or sometimes duplication of your terminal rays. Associated abnormalities include vertebral abnormalities, a femoral deficiency, syndactyly, or radial aplasia. The different syndromes that can be associated is Werner syndrome, and that's the syndrome with premature aging. These are the things that sometimes you'll see on TikTok or on the other videos of a 12-year-old that looks like a 60 or 65-year-old man. Tibial diploplodia, which is what you're seeing here, where we have duplication of our terminal rays. Split hand foot syndrome or ectrodactyly, which although this can be pretty significant, these patients are often very functional and oftentimes surgery is not indicated. And then micromelia or brachiocephaly, which can actually be pretty significant and sometimes not survivable. In terms of our classification systems, I would say for a classification system for anything, ideally, it's going to incorporate some treatment guidelines. So a classification of a 1BX would be associated with a specific treatment. Likely or ideally, they would help determine prognosis, and then finally be discrete enough that they can be useful for research. So when you're looking for a certain type of deficiency, you can look them up and be assured that you're talking about apples to apples or oranges to oranges. In terms of all the classification systems that we use, the one that actually is really good at this is the Linke classification system for spine. In limb deficiency, we're not so great. So let's talk about how we classify tibias. The most common would be the Jones classification system. And if we look at how we use this one, this is basically based on your x-ray appearance. Your 1A and your 1Bs will both not have a bony tibia, but what distinguishes a 1A is the distal femur is deficient. That distal femur deficiency is telling you that there's no cartilage analog for your proximal tibia. A 1B, your distal femur is going to look pretty normal. And the reason you see this little dotted outline is you're not going to see that cartilage on x-ray, not till much later. So these two, the tibias can look very similar in a 1A and 1B. The femurs will be different. When you get to a 2, you're able to see part of a cartilaginous tibia. When you get to a 3, you have your distal tibia, but not proximal. And when you get to 4, you have a tibia that's short, but a significant diastasis down here through your ankle. With Colanchi and Dawes and Weber added is some description of the foot. And then Weber actually added a point system that you would put in that would help you decide how functional that limb would be expected to be. Paley's classification is much more descriptive when you're looking through here. But the one thing that Paley's classification does is it's a description that's designed to help you decide what reconstructive procedure you're going to do. And every one of these types is associated with a reconstruction, not an ablation, which sometimes is going to be more functional. In terms of treatment, remember that you're focusing on function, not length. And what we challenge our residents and fellows to do is we say, look at that particular limb, look at its bony elements, and ask yourself the question, what do I have to do in terms of reconstruction to have this limb work well? And there's a couple things that you'll look at. So one is going to be the quality of the knee joint. Second is going to be the quadriceps function. And then lastly, what's the quality of the ankle and foot? And remember, our little spring man that we're looking at, when we're looking at these things, can that knee joint bend through a range of motion and absorb force? Can that quadriceps work effectively? And we're looking at the ankle and foot. Do I have or can I create a plantigrade stable foot for weight bearing with a functional ankle that can be that spring to cushion weight bearing, and also that spring for propulsion? When we look at things specifically, this is the easiest question on the orthopedic end training examination. When they show you a tibial deficiency and say there's a 45-degree fixed knee flexion contracture and no active knee extension, the answer is always a knee disarticulation, because a fixed knee flexion contracture with no knee extension is a non-functional limb distal to the knee. If they have active knee extension and a short tibia, usually the answer is synostose the tibia to the longer fibula to gain length. The next question is going to be, what's your ankle and foot look like? If you have a functional ankle or foot, you want to optimize it. And by functional, it doesn't have to be perfect, but maybe there are some procedures you can do to make it closer to perfect. If it's a non-functional ankle or foot, you're usually better off with either a Symes or a Boyd amputation. And I would say that tends to be center specific. At our center, the prosthetics people by far and away prefer a Symes amputation over a Boyd. And remember, when we say functional ankle or foot and optimize, can we build this device, we would say, whether it's a prosthetic or a limb that's going to have functional range of motion, be able to support weight and give us propulsion? All right, when do you lengthen? Well, a couple of things. You need to have a stable knee. You have to have a limb that's lengthenable, and by lengthenable, I mean adequate length. You have to have ankle stability and the functional foot. I would tell you that a fused ankle is not really a functional ankle. It's stable, but not functional. Some would disagree with that. Let's talk about fibulas. When we talk about fibulas, so the definition is similar in that we have a reduction or absence of the fibular or postaxial element within the long axis of the limb. But again, you may have intact skeletal elements distally. So remember, with our Franz and O'Reilly, a terminal means not everything is there, but we can certainly have some elements there. And then a complete means you're missing something. So here we have a terminal deficiency in that we have a foot, but it's only a 3-ray foot. Notice how that foot and ankle is in a valgus position, and our limb is pretty significantly shortened. Also of interest, I would tell you that there's often an apex anterior deformity in the tibia, and this little dimple is always going to be right over the apex of that deformity. And then there's our x-ray showing you a complete fibular deficiency, our apex anterior deformity, and then our complete coalition. We'll talk about that in a second. So the clinical picture is that planovalgus foot. Here's a great example of it. The limb is always going to be short, which can be variable. That apex anterior tibial deformity, and then the deletion of the postaxial side of the foot. There we see it again on the opposite side. Associated abnormalities, the planovalgus foot. Proximal femoral focal deficiency is associated with the fibular deficiency. It's often bilateral, more than 50% of the time. The deletion of our elements. And I should have another little bullet here saying that you often have a very complex coalition between your talus and calcaneus. And when I say complex, complete should be the word, and that there's often no joint at all. They're completely fused. In terms of our classification systems that are published for fibular, so once again, we have our ideal that we're trying to reach. And once again, I would tell you they aren't so great. The Coventry is a radiographic description. Ackerman and Calamchi added the function of the foot with it. Birch in Texas was very critical of both, saying that neither one affected prognosis. In a review of his series, he found that there were two things that really did affect the prognosis. So one was the quality of your foot and ankle, and he found that you needed to have at least 3 rays to be able to have a stable foot. So once again, remember our little spring man that we're defining. If you don't have a good foot or ankle, oftentimes a Symes or a Boyd is going to be the way to go. Paley has a very complete description looking at not only the tibia and fibula, but your foot and ankle as well. And with each of these, each classification has an associated reconstruction solution, where a type 1 is you have a pretty good knee and ankle, all you really need is length. And type 2, you don't have a very stable ankle, so that needs to be created. And 3 and 4, you have not only an unstable, but an abnormal that needs to be reconstructed. In terms of doing that, sometimes that can be a pretty significant procedure. Okay, that last little thing that popped up, what I was trying to show is he only talks about the ankle and the hind foot, not the remainder of the foot. So once again, with fibular, it's the question that we ask our residents and fellows. What do you have to do with the limb that you have to make that work well? And that's going to help guide your reconstruction, whether that reconstruction is headed towards limb salvage or that reconstruction is headed towards an amputation. So remember our man. So one is, how much length do I need? What's my ankle? What's my foot? So one is, if your length is greater than 50%, we would say that's lengthenable. If it's less than 50, probably not. You're headed towards a Symes or a Boyd. And then when you look at the foot and ankle, if it's functional, make it even better. And if it's less than a 3-way foot, Birch would tell you you're not going to be able to make that better. So let's just look at one quickly. And this is a class 3. And in terms of what you have to do, pretty significant foot procedure in terms of release and fusion. Then you're trying to reconstruct the ankle. After all that's done, then you have to lengthen it. In terms of function, Paley presented at POSNA looking at a matched group of patients who had had a Symes amputation or a reconstruction. Looked at quality of life, the 50-yard dash, whether that be a run or a walk, their satisfaction, and whether or not they were repeat. And he looked at it and said, hey, this is a big success of this limb salvage in that the results are basically the same between the two procedures. I would look at it and say, the patients who had the amputation had one surgery, had an average length of stay of 2 days, where the patients who had the reconstructions were averaging 6 surgeries, had still not completed their whole clinical course, with a total time in the hospital of almost 45 days. And if the best you can say is that huge intervention matched the functional outcome of the other, I'm not sure that's a win. We could have a big debate about that, but I would say my 2 cents is I'm not sure that's a win. So let's talk about PFFD. Proximal femoral focal deficiency is really a spectrum of defects that affects the femur itself, the hip joint, the knee joint, and the musculature across the hip joint. Clinically, it's going to be a short thigh, a fixed abducted and externally rotated, that has been described as looking like a ship's funnel. And this is what a ship's funnel looks like. You don't see these anymore, but this was before HVAC was around. Associated abnormalities, fibular deficiency, a valgus foot, which really is a fibular deficiency, other limb abnormalities, and then bilateral. Remember that first picture of that patient with the upper extremity. Here she is later, showing the upper extremity not yet reconstructed, and then her fibula deficiency and femur already reconstructed. So what are the clinical effects? Your femur is short, your hip joint can be variably dysplastic, knee joint unstable, and the musculature abnormal. In terms of what do we try to do with that femur? Well, we try to lengthen it or correct it. Hip joint, correct it or stabilize it. Knee joint, stabilize. And then musculature, we can't make the muscle stronger, but by realigning our power, make it more balanced. So what's that look like in terms of fixing it? Well, potentially lengthening or lengthening with a prosthetic, the hip joint stabilizing with surgery or a prosthetic, the knee joint, cankle, fuse it, plus or minus prosthetic, and then the musculature balancing. So what are the specific procedures that we could offer these patients? Well, one would be lengthening. One would be no surgery at all. A Symes amputation for an abnormal foot and ankle. Knee fusion for an abnormal knee. Potentially shortening. We'll talk about that in a minute. Thigh reduction or turnaround of Van Ness. Everything but lengthening is going to involve a prosthetic. And so this is working with the prosthetic people to say, what can I do as a surgeon to make your prosthetic work the best? So let me show you an example. This is an adult who had no surgery at all, has a flexed hip, a flexed knee, an inefficient post, and what I would say is an impossible prosthetic, in that because her foot and knee are so far in front of her body, you can't fit a prosthetic to her limb. Instead, she uses this small stool that she's basically sitting on that aligns with her mechanical axis better. That's what her x-ray looks like. And here's what we did. Her hip joint was actually pretty good. We fused our pseudoarthrosis, fused her knee, took her non-functional foot, and we're able to put her into a prosthetic that now can be an efficient one that she can walk around in. So let's talk about what we do when we see him as a kid. No surgery is what you do initially, and that most surgical procedures are delayed till about age 4. And there's a couple of reasons. One is the hip stability is not always apparent early. Second, they have unlimited cardiopulmonary capability, which allows them to use an accommodative prosthesis, where we basically take that limb and stuff it into this limb that lets them get around. What's their limb look like? Here we're trying to straighten that limb out to make our post more efficient. Over time, as this femur lengthens, it's going to make our accommodative prosthetic less functional. We customarily incorporate a knee, which even toddlers can use very well. So let's look at this one. There's our inefficient post. As that patient grows and that femur gets longer, paradoxically, that decreases their function. What we do to fix them is you'll fuse that knee to essentially convert this limb into a thigh. And if you take a non-functional foot away, now you have a thigh and allows you to fit them as an above knee. Right now, this limb is too long. Here's our ankle joint, but we've ablated at the knee and at the hip. We're going to catch up over time. Here's that patient initially, and then here's a similar patient later where we essentially caught up. Now, can we make a biologic knee? And the answer is yes. And that's with the Van Ness rotation plasty. So if we have a stable ankle and functional power across it, we essentially convert this ankle to a knee and then have that patient function as a below knee. Does it work better than a prosthetic? Look what I can do with this biologic joint that I can't do with a prosthetic. I have motor power across it. So that patient can actively flex and extend through their knee joint, which makes that a more functional prosthetic. Allman years ago showed that this did work better using a gait lab. And then Flaccari subsequently looked at patients and said, they function about the same. I would tell you that's because our prosthetics are better, not because the surgery's any worse. And then here's a patient that I'll show you that can do
See that all the
something
way out
that
straight.
no
Back up.
prosthetic knee joint can do.
And down.
She can actively
And then go
flex
back
and
down.
extend through her knee.
And up again.
All right, so when we talk about prosthetics, one of the difficulties with the prosthesis is there's no real motor control in the lower extremity prosthetics. And we're always working between a cross of stability and mobility. The more stable I make your prosthetic, the less mobile it is. And the more mobile I make it, the less stable. And think of it as trying to create something that you can stand on and will never fail, will never buckle or cause a problem. But when you want to walk on it, will swing smoothly and allow you to do that. Now, a C leg lets you do that. But we don't have sea legs for little kids yet. But with this microprocessor control, this allows patients to walk up and down stairs, even as a double above knee amputee. Never before could that happen. In terms of our prosthetics, some can be a very simple foot or a foot that actually can act a little bit like a spring, and then coupled with a knee joint can give us more of that spring man in terms of function. The ideal spring man is our blade prostheses, but these blades really only work for running. And if you see these patients, they can't stand still. They're kind of bouncing around all the time and they can never get that spring to stop. So this is a prosthetic that works great for running, but not for standing. All right. Now, think of a prosthetic in kids as something to help you do what you want to do. And if I could draw a corollary, think what a truck is. A truck is something that helps you do something. So this always appeals to our male residents. We say when you're a little kid or a baby, this is the truck that you want. Looks like a truck, but is padded. That baby flings this at your face. It's not going to hurt you. It's not going to go through the wall, but it's not really functional. This is your satch foot. It's padded, but doesn't do much more than that. As you get a little bit older, we start adding some function to that truck. So this truck is going to do a little more things. This one even more. You get to where you could really beat these up as a prosthetic, so that truck needs to be stronger. And then as you get older, we add more capability to that truck. This is a remote control one that you can drive around, but you would never give something like this to a toddler. They're going to hurt themselves or somebody else. Then as they get older, this is the truck the 16-year-old wants that they can drive around. And then this is the special function truck they can go off-roading with that would be correlating with our blade prosthesis. In terms of what do we have to look for in the future, this would be a whole talk in and of itself, but just a summary is the targeted muscle reinnervation, and then the RPNI, the regenerative peripheral nerve interface. The RPNI is really just sticking the nerve ends into any muscle, where the targeted muscle is you have very specific ones. This is something that we started doing to allow our motor-powered prostheses to function better, but found that we had much less phantom limb pain or limb pain. And so it's useful just for that alone. With the osseointegration, this is not something that's come down to kids yet, but using it in adults and select patients. But boy, that's going to be the future, I think. And that most problems that we have in prosthetics are really at the bioprosthetic interface. And if we can take that away and make that work better, it's going to be awesome. With our transplantation, that's total hand transplants. Right now, our difficulty is while you give that person a hand, you give them a chronic disease in that they're essentially can have the rejection that has to be controlled for their lifetime. So the indications are few, but that's an excellent area of research. In terms of prosthetics, with our 3D printing, our turnaround for the prosthetics is much faster. We can use that for our modularity and miniaturization. So take those great things that we're doing in adults and make them smaller for kids. The microprocessor control is what makes our C-leg really work and work well. We're working on a Bluetooth neural interface where you'll essentially dock your prosthetic with your brain or your muscles. If we could figure out a way that we can make the batteries last longer or charge the batteries through the skin without burning you, this is really going to be something in the future, as is the osseoperception. One of the big difficulties with the prosthetic is there's no sensation through it, but we're working on ways to give you, it's not perfect sensation, but some sensation. In summary, it really takes a team for these patients. You're combining biology and technology. Earlier is better. What we try to do with our surgical interventions is have that patient's developmental milestones parallel normal. In terms of what can these kids do, we have some limb deficiency camps. You can ski in Georgia, so that's a mountain where we have to make the snow. But we get these kids out doing everything on the snow, water skiing. Here we have somebody on the ropes course. I'd say you have to look close to see that that's a bilateral lower limb prosthetic. This is at a camp that I would take my able-bodied boys to when they were younger. I would be the camp doctor. And this is outside the pool where everybody's limb come off and they're in swimming and doing everything. And my kids used to say, "Hey, are we going to go to that camp for those kids with extra arms and legs?" And it's like, well, extra, but not really. But really, it's function. And that's what we're trying to get these kids doing. So that's me. And I know we had to go very quickly through things, but if there's questions, comments, or other things that you'd like to follow up with, that's my email address. And of course, that's what allows worldwide collaboration. So that's what I have. So I'm going to stop sharing at this point.
Yeah, thank you
And
for a very beautiful. Just let me remove the pin. Yeah, fine. So let's take a few couple of questions we have. The first question is, what was done for the case with fibular hemimelia with complex foot deformity and multiple synostosis child? You showed one case.
okay, so that patient where I showed you that picture, I said, let's go through our algorithm. So the first was, is that tibia lengthenable? And so I'll say that tibia was 55% of the length of the opposite side. So you would say, yes, we could lengthen that tibia. One thing to keep in mind with congenital limb differences is while the absolute difference in the limbs will change as that patient grows, the percentage difference remains constant. So then the second question is, do I have a functional foot and ankle? No. And then can I make that foot functional? I would say no. So that's a patient that ended up with a Symes amputation. So one surgery addressed our non-functional foot and ankle and also addressed our limb length inequality, that our limb length can now be accommodated for in the prosthetic.
Okay, good. Then there is a question from Busha. What age do you prescribe a prosthesis for a child with a terminal transverse deficiency of the upper limb through the forearm? And what prosthesis can be most beneficial for young kids?
So the upper limb prosthetics are a little different than lower limb. And so with lower limb, if you say that prosthesis is a tool, what do I need it to do? You say, I need it to stand, I need it to walk and run. When you say, okay, well, what do I need to do with the upper? You say, oh, I want it to be a hand. So I want to have sensation. I want to be able to pick up things, manipulate things, and do things. Even with our Da Vinci hands, our most complex prostheses, we're not quite there. And so with a child, usually we start with occupational therapy. And I would tell you, most children with a mid forearm transverse deficiency, there are very few things they can't do compared to a normal child. So usually that prosthetic is going to be prescribed much later, when they're 5 or 6 years old, and either want it for cosmesis or are finding specific things that they can do with it. Now, if that amputation is an acquired amputation, that's when we'll use our TMI. And what we're really trying to do is create 6 motor sensors that will give us 6 potential axes to power prosthesis in the future. And that's a whole nother hour talk to go through that.
Yes. And then there is a question from Siddharth. How would you protect the insensate heel pad flap or reconstruct, which you showed in one of the case? And next plan of the management if the flap or the reconstruction develop recurrent ulceration.
Okay, so tough one. So the way that we protected that is we had an insert that went into the patient's shoe that was a gel insert, and then told those parents, hey, this guy always has to have shoes on to protect it. And then the parents, that it was their job. We said, you got to look at this every day to make sure that it's okay. Both parents were Harley Davidson motorcycle riders, and to look at them, you'd say, "Ooh, that's a pretty rough crowd." But boy, they did a great job taking care of that patient. I've seen him as a young adult. He's now in his 20s, and that flap has survived. In terms of what would you have to do if it didn't survive, the only viable option is a free flap. And once again, with a free flap, you'd have to take one of his vessels, either his perineal or his posterior tib, and still it would be asensate. So you could replace it, but not necessarily make it better.
There is a question from Thomas. Please unmute yourself and
Yeah,
please.
yeah. Thanks,
Hey.
Mike, for that very pragmatic and very practical overview. I must tell you, in our country, in India, we have a few problems. One is about the culture that we are in. They refuse amputation or ablation of the limb. And the second is about cost and the need for repeated procedures. And the third is the inaccessibility to good high-level prosthesis. So we are hampered by these three factors. In a limb which you would ordinarily ablate in the West, we are forced to keep that and probably do an extension orthosis or try repeated multiple surgeries, like you said, which doesn't function at all at the end of it. So what do you think you would do in our situation?
So I had gone to El Salvador a couple times as a visiting surgeon, and the exact same three problems exist. So I think some things that will be changing is, one, with the surgical planning. Ideally, we have a saying, we like to be one and done. So do the surgery and then not have to repeat it over time. With the 3D printing, that is going to bring down the cost of the prosthetics and the manufacturing over time. And so that's going to be very helpful. The difficulty we have now is the 3D printers aren't able to really print in the material that we want them to print in. They can't print as durable, but we're getting there. And that cost is falling significantly. And honestly, I think that's what's going to make the big difference in the future. And then in terms of the prosthetics, so that C leg, that computerized limb that I showed you, just the knee component cost about $60,000. It's outrageously expensive. But over time, those prices are going to fall significantly.
Yeah, thank you. So, Mike, this was really a difficult topic. And I know that one thing I always feel is that we don't have a great solution or 100% solution for these problems. And particularly when what Thomas said, that our patients don't accept processes or amputation that well compared to your country. So it's a big challenge for all of us. But still, the way you explained the problem and you really gave a practical suggestions that 6 surgeries or 7 reconstruction surgeries, and at the end, the function is not really that comparable with the processes, is really very important for all of us. So thank you very much. I really appreciate that your vast experience was seen during each comments you made during the lecture. So thank you once again, and we will definitely have you for future sessions with us. Thank you.
Okay, well, thank you for having me. This was great.
Yeah, thank you.